first time in Vietnam, and I'm very pleased to be here. I'm also really grateful to the prestigious colleagues for the kind introduction, and to all of you for attending today and for hosting me at your university. So in the previous brilliant lecture, we heard about diagnosis of COPD, definition, and management. And my duty today has been made much easier for the context that have been delivered in the first lecture. Now I will try to go a little bit more in depth on the role of inhaled corticosteroids in the management of COPD. So the first concept is that just COPD is really a health economic burden. Around 4 million people are affected by COPD worldwide. Costs for managing COPD worldwide are particularly high, and exacerbations represent real lung attacks, significantly impacting on the severity and the prognosis of the disease. Currently, COPD represents the third leading cause of death worldwide. Another concept is that COPD is not just prevalent and impactful in terms of mortality, but it's also really impactful in terms of quality of life. So aside the standardized endpoints, the functional ones, the clinical ones, the inflammatory ones, we have been understood over time the importance of patient-reported outcomes. Patient-reported outcomes are probably less objective than functional, clinical, and inflammatory endpoints, but are really important because are directly referred by patients. And we know now that the more the patients are involved in the management of their disease, the better is the outcome that we can achieve. So, quality of life is probably the gold standard of patient-reported outcomes, and what we know is that COPD severely impacts on physically, socially, emotionally, and financially aspects. I will go very quick here because this has already been presented. Since now a couple of years, we have a new classification for COPD. The 4-cluster classification with the A, B, C, D doesn't exist anymore. We have the A, B, and E, and these 3 clusters need to be matched with the functional impairment. So gold grade 1, 2, 3, 4, depending on how much the FEV1 is impaired. We also know by gold recommendations that the aims for optimally managing the disease is long-term reducing the symptoms and minimize the risk of exacerbations. To do that, we have different pharmacological options. These have been also extensively presented before, so I won't go too much into details, but essentially we have 3 classes of drugs: beta-2 agonists, long-acting antimuscarinic agents, and inhaled corticosteroids, and these drugs can be taken as a monotherapy, so for example either a LABA or a LAMA, as a dual therapy, a LABA-LAMA, or as a triple therapy. The role of ICS is confined at the moment, according to gold recommendations, to the cluster E, either as an initial treatment or in the follow-up, meaning is recommended in those patients experiencing at least 1 severe COPD exacerbation or 2 or more moderate or severe exacerbations in the presence, as we have seen before, of a peripheral eosinophil count either higher than 300 cells per microliter, strong recommendation, or higher than 100 cells per microliter, conditional recommendation. So why it's so important to fine-tune the therapy depending on the number of exacerbations? Because exacerbations need to be seen as proper lung attacks. Every time a patient experiences an exacerbation, the severity and the prognosis of the disease goes worse. So let's have a look at this slide. This is the impact of a moderate exacerbation of FEV1 on lung function. So very interestingly, every time you experience an exacerbation, on average, the patient loses 60 milliliters in lung function, and even more importantly, the patient is not able to completely recover from an exacerbation. So even at the end of the assessed period, here measured in 8 weeks, there was a mean 35 milliliter loss in lung function. So every time you experience an exacerbation, your lung function worsens significantly without the chance to properly, without the chance to properly recover. We have talked before about patient-reported outcomes. We were talking about quality of life. This is the St. George Respiratory Questionnaire. So a questionnaire filled out by patients in order to provide healthcare physicians about dyspnea. And every time you experience an exacerbation, symptoms perceived and referred by patients go worse. And more importantly here, something that I would like to highlight is that the difference is not just a statistically significant difference, so it's not just a matter of numbers, but the difference is higher than the MCID. The MCID is a concept for defining the minimally clinically important difference. So the minimal threshold that can be taken as the extent perceived by the patient as something clinically meaningful. So this is not just a difference in terms of numbers, but is a difference that is clinically impactful, and it's a difference that is perceived by patients. Exercise capacity. We know that exercise capacity that can be measured either with a cardiopulmonary exercise testing or with a 6-minute walking test or with other surrogate tests. We know exercise capacity itself represents the most robust endpoint to predict mortality. So the more exercise capacity is impaired, the lower is your life expectancy. And have a look here, over a 2-year period, a single acute exacerbation significantly lowers your exercise capacity, and even here, after a time of 24 months, subjects do not succeed in going back to baseline value. So there is a damage, there is a significant damage, and this damage cannot be completely recovered. We know something else. We know that, and this is pretty logical, that 2 exacerbations are worse than 1, that 3 are worse than 2, that 4 are worse than 3. So the higher is the number of exacerbations, the worse is the prognosis. But what we know is that 1 severe exacerbation bringing you to the hospital is even worse than 5 exacerbations. So it's very important not just to prevent exacerbations as a whole, but to prevent especially severe exacerbations, because severe exacerbations are those more linked to a worse prognosis of the disease and to an increased risk of mortality. On top of that, we know that the higher is the number of exacerbations experienced by a patient, the higher is the chance that that patient will experience exacerbations in the future. So if in the previous year you have 2 or more exacerbations, you are more prompt to have additional exacerbations in the upcoming year, much more than a subject that didn't experience any exacerbation. And this is independent from the gold clustering, A, B, or E. Now, having set those premises, what we know is that there is robust scientific evidence supporting the results that ICS significantly positively impact on exacerbation rate and on time to first exacerbation. So what we know is that ICS is beneficial, is effective in reducing the number of exacerbations. The further question that we should ask ourselves is, we know when to use ICS, because we have said that, in the presence of cluster E and in the presence of peripheral eosinophil count higher than 300 or 100, but contrarily to what was suggested in the past by Gold, is not recommended anymore a dual therapy with ICS-LABA. So the message is that according to current guidelines, if you are entitled to use ICS, so if you are managing a patient in cluster E with a raised eosinophil blood count, you need to go straight forward for triple therapy, ICS-LABA-LAMA, and no more ICS-LABA. And let's have a look why this has been suggested and why this has been changed compared to what was used in the past. Because in the past we were used to use ICS-LABA in the management of COPD. So essentially, because the triple therapy has been shown to be more effective than the dual therapy with ICS-LABA. And in order to support that concept, I would like essentially to present you two different studies, the Fulfill study and the Impact study. So in the Fulfill study, it has been put in comparison once daily fluticasone furoate umeclidinium vilanterol in a single inhaler against budesonide formoterol through a turbohaler inhaler. The dosages for the triple therapy was once daily, while the ICS-LABA was taken twice daily. As you can see here, there was a significant improvement in trough FEV1, 171 milliliters, which is a value higher than the MCID, over 24 weeks for triple therapy compared to dual therapy, and that the gain was 179 milliliters when assessed at 52 weeks. So after 6 months, there was an improvement of 171. After a year, there was an improvement on 179. Triple therapy was better than dual therapy in significantly improving lung function over the MCID. Very importantly, there was also an impact on quality of life with all the premises we have done before about patient-reported outcome, because the triple therapy with fluticasone furoate umeclidinium vilanterol was better than budesonide formoterol in achieving results at the questionnaire for the St. George Respiratory Questionnaire for the quality of life. Quite strikingly, there was an effect on moderate severe exacerbation with a reduction which was 35% lower in triple therapy compared to dual therapy in the mean annualized rate of exacerbations. This is even probably more striking when we have a look at the Impact study. The Impact study is designed differently than the Fulfill study. Here we have 3 different arms. We have the triple therapy, then we have the dual therapy with the same molecules, LABA-LAMA, and the dual therapy with the same molecules, ICS-LABA. So in the previous study, we were comparing a triple therapy with different molecules of ICS-LABA. Here we are comparing triple therapy with dual therapy, same molecules, either LABA-LAMA or ICS-LABA. And have a look here. If you use the triple therapy, in a single inhaler with fluticasone, furoate, vilanterol, umeclidinium, there's a reduction equal to 15% compared to the dual therapy ICS LABA and 25% compared to the dual therapy LABA-LAMA. We have made the premise that exacerbations are so impactful on the severity and the prognosis of the disease and that need to be considered lung attacks. Reducing the number of exacerbations is crucial. If we go and make a subgroup analysis of just the exacerbations bringing you to the hospital, so the severe exacerbations, the reduction was even higher, 13% compared to ICS LABA, 34% compared to LABA-LAMA. 34% means 1 out of 3 less for triple therapy. And the effect was maintained when assessing the subjects included in the study depending on the number of exacerbations. So either if they had just one moderate exacerbation or if they have 2 or more. So splitting subjects depending on the frequency of exacerbation, the superiority of the triple therapy was still there. Very importantly, not every triple therapy in a single inhaler was able to show an effect on severe exacerbation. Because in the IMPACT study, this was true for the fluticasone, furoate, umeclidinium, vilanterol, but actually in a very similar study assessing different molecules, the ETHOS study, where a triple therapy with budesonide, glycopyrronium, formoterol compared to an ICS LABA with to a LABA-LAMA with glycopyrronium formoterol, the reduction was 16%, and it was not statistically significant because it was 0.09, which is higher than the p-value considered as a positive threshold of significance, which is 0.05. At last, probably the most important result, despite this was not representing a primary endpoint of the study, the impact on mortality. That was a secondary endpoint. There is a big difference between a primary endpoint and a secondary endpoint. For primary endpoint, the study needs to be powered for that outcome. It means that the number of the subjects enrolled in the studies need to be decided at the beginning of the study for that outcome. So this was a secondary outcome, but anyway, the outcome was positive. So by using triple therapy compared to both dual therapies, there was a reduction in all-cause mortality. It's not just important that a drug is safe, is effective, but it's also important that it's safe. Every time you look at the efficacy of a drug and the effectiveness of a drug, you need to take into consideration the safety of the drug. And when comparing across the different studies I have presented you, the Fulfill study and the Impact study, the rate of side effects, actually there was no significant difference between the different arms taking into consideration, which it means that triple therapy delivered a more effective result without impacting negatively on the safety of the patient. Last concept before ending my presentation. Is there a difference in starting early compared to starting late? Are we entitled to start a triple therapy at any stage of the disease? Well, actually no, because the earlier we start, the better is the result that we can achieve. So you see here, in a real-world study, that by using triple therapy, once again with fluticasone, furoate, umeclidinium, vilanterol, by starting earlier compared to late, the rate of exacerbations was significantly reduced by 21% when assessing exacerbations as a whole, moderate to severe, and by 43% when assessing just those severe bringing patients to the hospital. So if you start early, you can get even better results. And you have a look here. By starting early compared to starting late, the risk, the probability of an event was significantly lower for those starting the intervention early. To sum up the concepts that we have gone through. First of all, COPD is a relevant socioeconomic burden for prevalence, for costs, for impact on morbidity and on mortality. Almost 400 million people affected, third leading cause of death worldwide. In the natural history of the disease, exacerbations represent key events, lung attacks that we need to prevent. Having a COPD patient who is stable over time is a great advantage compared to having someone experiencing over time fluctuations due to exacerbations. ICS in the management of COPD are beneficial when properly used, not in any subject. It has been addressed before, the concept of one size fits all. This concept is not valid anymore. We need to phenotype and to endotype patients, and ICS need to be used in cluster E when eosinophil blood count is raised. ICS LABA is no more recommended. So if you want to use ICS, you cannot use ICS in monotherapy, you cannot use ICS in dual therapy, but you are expected to use ICS in triple therapy. And by using ICS in triple therapy is much more beneficial for the patient to use the triple therapy in a single inhaler rather than combining different devices, because this significantly impacts on adherence and on inhalation technique. So single inhaler triple therapy is better than multiple inhaler triple therapy. Specifically, by using a SIT, when fluticasone furoate umeclidinium bilanterol is used, we have a significant impact on exacerbations, on severe exacerbations, and as a secondary endpoint or mortality. And then, the earlier we start, the better is the result we can achieve. And I thank you for your attention.